sorry for the technical difficulties. All right. So thank you guys for coming in early today. This is actually, we did a couple lectures so far. So a lecture with primarily nursing and then primarily therapies. But the idea was to try to get everybody on the team involved and to be involved in the education series. These are not brand new ideas. They're lectures, a lot of them that you've heard, but we're hoping that we kind of turn it a different way so that it's more of a team-oriented approach to things. So let me just tell you first about what we're doing. So this was actually developed, the idea was developed by the neurospecialty team. It was kind of an initiative we had sort of, when I first got here, I kind of had the idea that we should all be thinking as a team, and all the topics that we think of as education series, it should be something that we do as a team. So it should be something where we're kind of looking at it so that to make ourselves stand out outside of a subacute. What makes us better than a subacute hospital, a rehab place? What makes us different is the way that we approach things in acute rehab. So every quarter we're going to do a different topic overall, and this quarter is going to be continence. And then within each quarter, so there's 3 months to each quarter, the first month, each month will be a different topic that we do a little lecture on or a workshop or something like that. And then the whole quarter is wrapped up in that. It's a work in progress, obviously. So we're trying to figure out the best way to record the lectures so that everybody can kind of have them, give you handouts, and then also try to make ways that we can kind of incorporate everyone so that it's kind of more interactive and not just me lecturing at you, because this is kind of a boring topic sometimes, especially at 10 o'clock at night.
I'm fascinated by this topic.
So, and we totally welcome, ideas that you may have of things that we could talk about in general. I think for spring of 2020, we're already getting started. It's going to be on mobility and reducing fall risk and communicating that. So that's going to be the topic we think for April, May, June. But if you guys have ideas of a topic, that would be really great to discuss with therapies and everybody involved in the team, nursing and therapies and physicians and everybody. Then that'd be a good way to get this started. So this block is going to be continence. So the first lecture series, now it's already February, but this was left over from January, is talking about what is continence. Then the next, in February, some of the therapists are going to talk about the implications of incontinence. And then in March, Lisa Glickstein and I and Jackie and maybe some other people from JFK will talk about the management of continence with some of the meds and bowel programs, time toileting, and all of that. All right? That didn't work. Sorry. Are you freezing me? Okay. Sorry. Okay, so let's get started. So this one the start of it is what is continence. So I want to give a thanks to Dr. Fleming. Were any of you here in 2011? Mm-hmm. Do you remember Dr. Fleming? Oh, yeah. And she gave a talk on bowel and bladder in the rehab setting. So I took a lot of her slides, so I want to give her some kudos for that. And then I also took some slides from a colleague of mine, Dr. Vasquez, she's from Texas. She's actually a pediatric PM&R doc, so I like a lot of her slides because they are fun, because they're peds. So this one I took from her. Let's talk about poop and pee in rehab. So if you start seeing some emojis, that they're all hers. To get started, I really wanted to say how much I appreciate the neurospecialty team in talking about this being the topic of continence and not so much just the topic of bowel and bladder management. Because, when you talk about bowel and bladder management, I'm going to give you anatomy and physiology. That stuff is really boring. And I'm going to try to make it interesting the best I can. But at the same point, our patients don't care about that anatomy and physiology. They really don't. They care about continence. They want to be continent, right? And continence, the word continence is already confusing enough. We have patients who are phasic. Can they really be continent if they can't really tell us but they have to go, right? We have patients who are, minimally conscious. They can't really get up. Can we get them to a point of continence, or, what does that really mean? And so, can those patients be continent? Those low-level stroke patients? What do you guys think?
Sometimes. I think some of them can.
So the thing about continence is not so much about having full function of your bowel and bladder, right? Continence is about how you control it, how you manage it, right? So the word continence in the Webster Dictionary, the definition is the ability to retain a bodily discharge voluntarily. So the voluntarily part is confusing because, if you're cognitively impaired, can you voluntarily actually do something? The actual word was originally in Latin, and it was actually referring to self-restraint, so it was actually more to do with sex back then. So it was about sexual continence. But the idea of continence is not so much about having the function, but it's about controlling it and having management of it. So we talk about, and this is what we do in rehab. This is the essence of rehab. It's not so much about trying to aim to have good bowel and bladder function. It's about knowing your disability and trying to work with it so that you can manage it, right? So we talk about this in rehab. Disease, you have a disease, which is the sickness. You might have a stroke. The impairment might be hemiparesis. The disability, or neurogenic bladder. The disability is that you can't control your bladder. You can't tell when the bladder has to go. So what we try to do is we try to get rid of the handicap. So the handicap is the role in society. So being able to function out in the real world, even with all of those disabilities, that's what we try to eliminate in rehab. That's the essence of what we do in acute rehab. In all rehab, but in acute rehab, we're really trying to get people out in the community. We're trying to get rid of the handicap. That's why we say disabled parking now, not handicap parking, right? Because we try to make it that we can go out and function with our disability. So these patients, they might have neurogenic bladder, they might not be able to control when they have to go or any of that, but the idea is to try to manage it so that they can go out and function in society. So the goal of rehab is not to fix the disability, but to get rid of the handicap, to achieve continence, right? So poop, we're gonna talk about poop first. So have you guys seen this before?
Yes.
So I'm gonna play it for you if you haven't.
Oh my God. It's a squatty potty commercial.
Totally cool. Soft serve straight. They're good at pooping. But you know who sucks at pooping? You do. That's because when you sit on a porcelain throne, it's muscle to kink the hose and stops the Ben and Jerry's from sliding out smoothly. Is that a problem? I don't know. Are hemorrhoids a problem? Because sitting at this angle can cause hemorrhoids, bloating, constipation, and a bundle of other crap. And seriously, unicorn hemorrhoids? The glitter gets everywhere. But what happens when you go from a sit to a squat? Voila, this muscle relaxes and that kink goes away faster than Pegasus laying sweet sherbet dookie. Now your colon's open and ready for battle. That's because our bodies were made to poop in a squat, and now there's a product that lets you squat in your own home. Introducing the Squatty Potty. No, Squatty Potty is not a joke. And yes, it will give you the best poop of your life, guaranteed. I don't just mean you bloated lords and hemorrhoidal ladies. I mean everyone.
About this, right?
King, unking. King, unking. It's simple science, really. Can't get the last scoop out of the carton. With the Squatty Potty, you get complete elimination. Spend too much time on the chamber pot. The Squatty Potty makes you go twice as fast for your money. I stream, you stream, and plop, plop, baby. Maybe you're sore from squeezing out solid globs of rocky road. The Squatty Potty gives you a smooth stream of froyo that glides like a virgin swan. Plus, when you're done, it tucks neatly out of sight, thanks to its innovative, patented design. Truly a footstool fit for a constipated king. So, if you're a human being who poops from your butt, click here to order your Squatty Potty today at squattypotty.com. You wish you tried it years ago. And if you don't trust the prince, How about your doctor? Shark Tank, HuffPost, NPR, Men's Health, Howard Stern. He poops from his butt. They're all crazy about the squatty potty. Not to mention the 2,000 Amazon users who gave the squatty potty 5 stars, including the author of this moving haiku.
Oh, squatty potty, you fill me with endless joy, yet leave me empty.
So order your squatty potty today. I'm not saying it will make your
dirty
poop as
about
soft
it.
as his cookies and cream, but I'm not saying it won't. Squatty potty, the stool for better stool. Pooping will never be the same. And neither will ice cream. What do you think? How does it taste? Is that delicious? Is it the best thing you've ever had in your life? There you are.
Oh,
It's
she's
lovely,
wrong.
right?
That's
Unicorn
just all
poop.
wrong.
All right.
Oh, no, I'm kidding.
So, I have no investment in Squatty Potty, but I just thought it was hilarious, and I think it's a great, you know,
It's a great.
it's a good, definitely someone in rehab is creating that because you know we're thinking about how to make things better.
And you give everyone footstools now in front of the rappers.
Well, I've had patients want use the garbage can to prop their feet up.
Yeah.
Yeah.
Let them go.
So to get started, we talk about bowels, and we talk about how bowel dysfunction can lead to a plumbing problem. It's the digestive tract is similar to a faucet and tubing. However, there are other physiological aspects. Oh, sorry. So bowels are, you know, they're controlled by a whole lot of different systems within the body, starting from the brain, going down the spinal cord, and then to all the nerves that go down to the gut and to going down from the stomach down to the intestines, down to the rectum, the anus and the rectum. Peristalsis is when we have the bolus of food that goes down through the stomach and the GI system, and it uses the nervous system that I'm going to talk about the different nervous systems. There's a contraction, it goes in giant migratory contractions, and those contractions go and they're more frequent after you eat. So those are the gastrocolic reflex, and it's more stimulated by fat and proteins. And those can be affected after spinal cord and immobility or bed rest. So there's different nervous systems, right? You have the autonomic nervous system and the somatic nervous system. The autonomic nervous system is split up into the parasympathetic and the sympathetics. The parasympathetic is in the GI system is where we have rest and digest. So that's the upper GI tract has the motility, the contractions go through, then it gets to the colon and it keeps going through. It's all about motility, and it's stimulated by these nerves in the pelvic region down here in the bottom of the spinal cord. The vagus and the splanchnic nerves down here, and the vagus nerve that comes out of the medulla up here. So those things innervate the parasympathetic system that allows rest and digest. Then the next system is the sympathetic nervous system. So that's your fight or flight. So the food's going down into the colon, and then the fight or flight stops those contractions down at the colon, and it tells the bowels to store the bowels there. That's innervated by the middle of the spinal cord, the lower portion of the spinal cord down here. And those autonomic nervous system parts come from the superior mesenteric ganglion and the inferior mesenteric ganglion. So again, the vagus nerve up top, the mesenteric and the mesenteric nerves and the hypogastric nerve down in the middle, those are the sympathetics, and then the pelvis nerves down at the bottom, the splanchnic nerve, that's parasympathetic. Then you have the somatic system, which is the bottom. It leads to the pudendal nerve innervates the muscles in the pelvic floor. So the somatic nervous system is the voluntary portion. That's the part you can actually control. That's the part where we increase our sphincter tone and we push, and we use the pelvic floor to push. So that's what allows for continence. So in a normal bowel function, you have all this bowel, all this bolus of food, the peristalsis going through the colon, and it fills up the internal anal sphincter. So there's an internal anal sphincter and an external anal sphincter. The external one is made up of the muscles. It's the pelvic floor muscles. It's kind of aligned with all that. The internal one is smooth muscle. And so the internal sphincter just relaxes as the bolus of food comes down. That tone that's normally tight gets opened up as the bowel comes through. Then the external sphincter tone, that's where we squeeze. Those are the pelvic floor muscles. That is coming from higher up in the cortex of your brain that tells you to squeeze and push, and that's continence. Okay. So again, there's a lot of repetition in these slides because again, half of them are from Texas and half of them are from Dr. Fleming. So if you see the unicorn, it's from the peds doc. So those migratory contractions of boluses of food go through from the colon down to the rectum. Then the stool comes down here and it stretches the muscles down here, and the internal anal sphincter relaxes. So these muscles, this is the puborectalis muscle, that is part of that muscle, and the external anal sphincter down here. That's what allows for the holding reflex, and that's what we tighten to hold the stool in. Ooh, sorry. Again, this is kind of saying the same thing. So for normal bowel movements, it goes down through the rectum. The puborectalis muscle is here holding it tight. The internal anal sphincter is loosening, but the external anal sphincter is holding. And the external anal sphincter is part of the pelvic floor, which is controlled by higher up, voluntary. Okay. And one more time, the voluntary activity is that the external anal sphincter is contracted and allowed to push through, so that part relaxes when we want it to. The levator ani, the external abdominals, the diaphragm, all of those push with the Valsalva maneuver, right? When we push down, then the intrathoracic pressure, the intra-abdominal pressure push and move out the bowels. So that's the normal bowel system. So again, we talked about the anal sphincters, that's really what controls continence. So the internal anal sphincter, that relaxes, right? With the bowels coming in, that part relaxes. That part isn't affected by spinal cord or brain injury. It's the external sphincter, that voluntary control, especially when you have spinal cord injury, right? Then you can't control those muscles voluntarily, so you can't hold it in. Ooh, sorry. So neurogenic bowel means something in this system is not working correctly because something in the central nervous system is impaired. A medical condition caused by an injury to the nervous system, which controls the colon, and interferes with the body's natural process for storing and eliminating solid waste. In spinal cord, so when neurogenic bladder really just means that it's not working because something in the nerves isn't working. But we usually end up talking about neurogenic bladder and neurogenic bowel in spinal cord. And I think it's because in spinal cord you can get down to the nerve level of what's not working. So in spinal cord, we talk about areflexive and hyperreflexive based on where the spinal cord injury is. So if you have areflexic, it's because of the lower motor neurons, lower in the spinal cord. Because down here in the bottom of the spinal cord, where the spinal cord ends, is called the conus, and because it forms a cone. And then the nerves come out here called the cauda equina, which means horse's tail, because it looks like a horse's tail. And that's when a spinal cord occurs and cuts off the spinal cord in this area, then you don't have the nerves going to the muscles and going to the external anal sphincter. So you have areflexic bowel. So it's just always open. So your parasympathetic bodies don't work. And the pelvic nerves, the pudendal nerves, those don't work either. So you're going to be incontinent because that external anal sphincter is always open. So when that internal one is filling up, that external one is always open and can just leak out. So same thing we just talked about, the parasympathetic bodies at the conus and the cauda the nerves, and the somatic nerves, those are all affected in spinal cord lesions, but at T10 or below. So you have lower resting tone. You don't have the spinal cord related peristalsis because the nerves are gone, and then you get excess water absorption and rounder stools, and you have basically an open anus that's always open. So you're always going to have incontinence when the internal anal sphincter is filled, right? You don't have the holding reflex. You're incontinent. So I think I had like 5 slides that basically say the same thing, just to say it in different ways. So the answer to that is you really have to just constantly get to it before it can leak out. So you have to do multiple times of evacuating using digital stimulation to try to, because you don't have the muscles to try, or the strength, muscle strength to push. So you gotta use digital stimulation to get it out. So you do it multiple times a day to try to really get it out frequently. The other form of spinal cord is when it's above T10. So then it's an upper motor neuron syndrome, and then you have hyperreflexic bowel. So all that spasticity is what we talk about when we talk about hyperreflexia. And so there's increased colonic wall and anal tone, and the voluntary control of the sphincter is always tight. So you're always going to retain the stool. It's never going to come out. So, so because that external anal sphincter is constantly unable to be relaxed and opened up, right? Because you don't have control of that. So you have a spastic tone of your external anal sphincter and of peristalsis, and things just get stuck, and so you have rectal impaction. So you have to disimpact, right? So at that point, you're not going to have an urge to go. It's just going to sit there. So you really do have to do a digital stimulation at a set time every day to try to get it out. And we're going to talk a lot more about these bowel programs and what we're doing with the bowel programs and bladder programs. But we're going to talk more about that in March when we talk about the management of continence. But this is really just so you understand why we do different things different ways. It's not just about, with a lot of our patients, they go spontaneously, but it doesn't mean that it's controlled or that they can manage it at home. If they're going spontaneously like that, that's going to be a problem. Right? So again, neurogenic bladders, it can be a neurogenic bowel, can be a lot of different things. It can be that you don't know you need to go. It could be that it's taking so long for it to go through because you don't have that motility. It could be that you get constipated and you have less than 3 bowel movements per week, or that you're not fully emptying. So you can have neurogenic bowel and still have bowel movements that are small because it kind of leaks around, it's not fully emptying. Or you can have incontinence or discoordination so you're just not going enough. We haven't talked about that. Problems with this is that obviously, you can have really bad constipation. If it gets really bad and it gets impacted, that could be a problem. And you can still have diarrhea as well, leaking around. And if you push hard enough, you might get hemorrhoids. And then the really bad problems are, you could have, if you have fecal impaction, you can have abdominal distension, nausea and vomiting. You can get urinary retention, so you can get to a point where you're so filled, and that's the reason why suddenly they're not completely going to the bathroom and voiding and peeing, because they're not emptying. There's too much there, they can't fully empty. So, a lot of times if we're noticing all of a sudden that our patients aren't peeing anymore, it could be because they haven't pooped. And I think we forget that a lot. And sometimes patients, they'll be in therapy and there'll be nausea and vomiting, and really the first question should always be, when was the last time they pooped? Because that might be making the difference. Obviously, if you're incontinent of bowel, you could have urinary tract infections or skin breakdown. And if it gets really bad, you could end up needing a colostomy or an ileostomy. And again, we'll talk more about those as well in March. Okay. The psychosocial implications, that's going to be talked about in the next session of implications. And if you have really bad problems, your bowel can perforate, you can have peritonitis, you can have full-blown infection in the back of in the whole abdominal area. You can have an ileus or a megacolon. So that's the end of poop. Any questions so far? All right. So the next section is about pee. So this was like in Vancouver, and I think this was the mascot of an initiative for like kids. So these are like the mascot of poop and pee. So the anatomy of the bladder. In the way we just talked about the bowel, and especially the sphincters of the bowel, right? The internal and the external sphincters, it kind of has a similar thing here too with the bladder. So you have your kidneys that are up here, right? They're processing all that urine, and they're processing all the fluids that go through your system, and they're getting rid of all the parts that you don't want. And then it goes down through the ureters. So these are the ureters that come into the bladder. And here, sometimes the bladder is called the vesicle. So this is the ureterovesical junction. And it goes down into the bladder, and then it goes down into the neck of the bladder. And then here you have your internal or intrinsic urethral sphincter. And then here you have the external urethral sphincter. So just like in the bowels, this is a smooth muscle, and it's and then this is striated muscle, or muscles that are part of the pelvic floor. So the external urethral sphincter is also part of the pelvic floor. It's also voluntary. Is it hard to see? Ooh. I have a driving problem. So, you know, we call bowels, the process of having bowel movements, defecation. We call the process of having urine is micturition. The bladder is like a balloon. It fills up and it stores, and that's the sympathetic system. And then when you empty, it's using the parasympathetic system. So we talked about the the ureters coming from the kidney, going into the bladder, and then the internal and external sphincter going down to the urethra. Okay. So again, it comes up from higher. So there's the control of the bladder comes from the brain and the frontal areas of the brain, and as well as there's the limbic areas. So limbic areas is emotional areas. So that's why, you know, when you get very stressed, you might pee when you're really stressed, or things like that, or get scared. So there's some limbic control and some voluntary control from the brain, and it goes down the central nervous system and the spinal cord, down through the brain stem. So the brain stem is really important. Do you guys remember the 3 parts of the brain stem? So you have the midbrain, the pons, and the medulla. And in the pons, in the midbrain, that's where you have a pontine micturition center that controls you having to urinate, and then you also have a pontine defecation center. So you really need to have function of the brain stem in order to be able to control your function of bowel and bladder. So a lot of our patients, we do have a lot of patients who have brainstem strokes, cerebellar strokes, all in that region. And so we expect that they're going to have trouble with controlling their bowel and bladder. So those signals go down through, and then you have signals into the spinal cord, and the spinal cord goes down and innervates the bladder, and then there's receptors within the bladder wall, and it stretches similar like a balloon. Yeah, there's a lot of mention in here that it's probably a little complicated. So then you have the pons. We talked about the pons, and it goes down, and it goes to the muscles of the bladder. So you have the detrusor muscle of the bladder, which contracts, and that's innervated by the autonomic nervous system, the parasympathetic and the sympathetic system. And then also down here, it goes down to the internal sphincter, which we talked about, which is the autonomic nervous system, somatic system. I'm sorry, the sympathetic system. And then down here, the external sphincter relaxes again, similarly to the bowels, and that's part of the somatic system and voluntary. So again, you have your storage phase, that's sympathetic, and then where your detrusor muscle is storing, so it's relaxing, that muscle is relaxing, and the sphincter is also relaxing. And then you have the voiding phase, or the phase where you're emptying. Voiding just means emptying. So when you get your high bladder volumes, then you get that sensation to urinate, and then the detrusor, the muscle of the bladder, contracts, the sphincter relaxes, and the external sphincter relaxes as well. So incontinence, there's lots of different types of incontinence, right? There's stress incontinence, where there's pressure on the bladder, which causes leaking. And then there's urge incontinence, where the bladder is spastic and it's oversensitive, and it also causes you to have frequency. So I talk about, I've been wanting to put this meme in. Because of you, she pees when she coughs, send her flowers, Mom's Day. Because, when you had that issue, then you had the stress. When you're coughing, it pushes down on the bladder and it causes leaking. So, thanks, kids. Then there's overflow incontinence, where it doesn't completely empty, and then you have frequent urination and dribbling. And then there's a mixed incontinence, which is combined stress and urge. And I think a lot of our patients complain about functional incontinence. I really knew I had to go, but I can't get there in time, and nobody can help me. So this is the part we really have room to grow and improve, and I think is to try to improve functional incontinence. We don't want patients to be incontinent because of a functional reason. We can fix that. So we gotta be owning that one. Anatomic, developmental, or temporary reasons for incontinence can be from infection or meds. So if you have a urinary infection, you might suddenly become incontinent. Or if you're constipated. We talked about that already. So
That's
I'm gonna thank Dr. Fleming for this picture. Neurogenic bladder, so again, it just means that you're not able to control the bladder, right? So the reflex pathway is what contributes to going. So if you don't have control, there is a reflex, and babies urinate by reflex. But it's really the pathways from the brain that allows you to stop or tell you when it's appropriate to go, right? So if you don't have that voluntary control, then you're just going by this primary reflex pathway. So a lot of our patients don't have the control, they don't have the control that comes from higher up, from the cortex, because it's affected by a stroke or some kind of neuro issue, and then they're just going reflexively. And we're always trying to catch that, right? We're always trying to catch them being incontinent and trying to get in front of it. So we'll talk more about that in March. There's lots of different things for neurogenic bladder. It doesn't have to be spinal cord injury or stroke. It really could be anything that's from the nervous system that's causing problems with the bladder, just like in the bowel. You could have lack of perception, so you could not know that you're filling up with urine and not have the urge to void. You could be unable to empty completely or not able to void. So you could retain, you could have urinary retention, which we see all the time, right? That could happen from frequent urinary tract infections or cause urinary tract infections. You can have incontinence, and let me see. Okay, so the biggest problems with urinary retention is that you can have reflux, and it'll go, the urine will go back up into the ureters, up into the kidneys, and that could be a big problem. You could have scarring in the kidneys, you could have hydronephrosis and swelling of the kidneys, you could get kidney stones. And neurogenic bladder can also be when you don't coordinate the urination. So your bladder contracts and your sphincter contracts all at the same time, you just can't coordinate it and go. So that kind of coordination is a big portion of, especially in spinal cord, where your bladder's contracting, your sphincter's contracting all at the same time, and you can't get it out. Again, then it refluxes back into the kidneys, and you can cause problems. We call that vesico-ureteral reflux, because this is the vesicle, these are the ureters, right? So it goes back, retrograde flow from the bladder into the kidneys, and it can cause pyelonephritis or kidney stones. So neurogenic bladder, when we're talking about upper motor neurons, you're not able to store. So if you're above the sacrum, above S2, like in spinal cord, or stroke or MS, then you get small, overactive, spastic bladder and might not have a good sphincter. So you're constantly going, you're having an overactive bladder. And so the meds we use for that are Detrol and Ditropan. Ditropan does really help with urinary frequency from an overactive spastic bladder. An upper motor neuron bladder is an overactive bladder, it's the same thing. So then you're not able to fully empty. So in upper motor neuron lesions, the answer to that is to go have time voids. That's why we have the time voiding, right? We're trying to get ahead of it. We're trying to get them to, even when they don't know that they have to go, we're trying to get them to go. We're trying to get them to go twice and void and completely empty as much as possible. And if really needed, then we do have to cath. In lower motor neuron, the bladder is not able to empty. So it's not spastic, it's not constantly squeezing. Instead, it's always filling and not able to empty. So that's usually from the lower motor neurons, the low portion of the spinal cord, S2 to S4. So you would have, again, a reflexic bladder, and maybe a sphincter that's tight, so it's just filling and not able to empty, so that you get a lot of urinary retention. That's why you see us using Flomax a lot. I think I just talked about this. The external sphincter stays closed, and so you could get overflow incontinence. The answer to this is to use intermittent cathing if you can't get in there, or if you can and it does come out, you can use a condom catheter. If there's problems, you could end up having surgical solutions to this. So again, we're going to talk about management in March, but you might end up with a stoma, a suprapubic tube. You could get further surgeries. There's actually stimulators now that you can put to try to help coordinate the bladder. But again, we'll talk about the meds and the different treatment options other than the stuff that we can do on the floor. So that's the whole thing. Any questions?
I have a stupid question.
Sure.
On
Yes.
that previous slide, vesicostomy, what is that?
I'm
Do
not
they
sure.
actually take,
They put a tube into the bladder, the vesicle, and it
that's
has
what
a,
they call,
I've never heard that term, so I'm not sure.
is that what they call like the surgery to have a suprapubic catheter put in?
Let's Google it.
yeah, Google it. That's what Google's for. I know I had a patient a long time ago with that, and it was, they managed it beautifully.
I'm
But that's a
assuming
long
it's
time ago.
like an ileostomy, right? So you have a bag that empties the bladder into, because an ostomy is very
Right.
I looked at it.
So a
quick
stoma
and I
would be
said,
the
"What's
same kind of thing,
vasectomy?"
where you're emptying.
I was like,
Okay, that makes sense.
Right, so other ways of managing a bladder that's not working.
Mhm.
So, more to come. February, implications of incontinence. And March, we're gonna talk about
it's a suprapubic cystostomy.
So it's
no,
the-
that's different.
Google-eyed.
A suprapubic cystostomy is a vesicostomy.
That's what it's saying.
Okay.
It's a surgical procedure for, oh, that's a mastectomy.
See?